Hello everyone, hello and welcome to aidsmapLIVE. My name's Susan Cole and I'm thrilled to be joined by an absolutely amazing panel to chat everything about HIV related stigma. I will introduce them all to you in a moment, but in the meantime, if you have any questions, do please get them over on Facebook and Twitter. So let's say hello. So first of all, we have absolutely brilliant Bisi Alimi, who is an internationally renowned public speaker, writer, activist, founder of the Bisi Alimi Foundation.
Yes, indeed.
That's right. And the first person to talk on Nigerian TV about being gay. And your TED Talk is one of the most inspirational, I hear, ever.
Okay.
But actually, there was a very interesting accolade today. The MP, Florence Eshalomi, said you were one of her favourite people ever. So how do you schmooze MPs?
Oh, well, you know, it's a Nigerian thing. So everywhere you see Nigerians, we always recognize one another. We always give each other shout out. So that's what you didn't hear from other panel, shout out. Nigerians always do that, you know.
Just
it's a Nigerian thing, yeah.
I did a 23andMe DNA test and I am more Nigerian than anything else.
Oh.
So Florence, if you're watching, I need a shout out.
We'll be giving you a shout out.
Yeah. Next, we have Dr Linda Vaccari, who is an infectious diseases registrar at Royal Free Hospital. Yes.
Thank you for having me, Susan.
It's wonderful to have you on, and you've previously worked in HIV at Croydon University Hospital, is that right?
Yeah, that's right. I worked there and I was running the ED opt-out HIV testing program under the supervision of HIV lead Dr Ian Cormack.
Fantastic. I'm very excited to actually have someone who's been to Croydon, because Croydon gets, like, people are always maligning Croydon. And, like, Croydon's a really cool place. So tell me one good thing that you liked about Croydon.
Fantastic team, fantastic sexual health and HIV team there, great passion, really going the extra mile when resources are low. So
fantastic. That's great about the hospital. Anything about the area? Or like, no.
Yeah.
We will move on.
Okay.
Yeah, cheers. Thanks
Save
for that.
by the bell.
Thanks for that, Linda. Next, we have Matthew Hodson, Executive Director of NAM aidsmap. Brilliant HIV charity. Check it out. Award-winning, and some of you may have seen Matthew on the internet. He is a little bit shy, but he is, I'm
very shy.
He's very shy, but
it's something I really struggle with, but I just have to come out of my shell and be here tonight.
Fantastic, yeah. Matthew is doing fantastic work around challenging stigma using your muscles sometimes.
Well, yeah, we like to think of them as socially conscious gym selfies.
Fantastic. Brilliant. Thank you. Will they be coming out during this podcast?
No. I thought I would dress up today.
Okay,
SCGA.
Yeah.
Fantastic. Love it. Next, we have Kat Smithson, Director of Communications and Engagement at the National AIDS Trust, the UK's HIV rights charity.
That's correct.
That's right.
Thank you very much.
We did work together for a while. So it was the policy charity, and now it's the rights.
Yeah, and I think that reflects what's needed in this day and age, really, to concentrate on rights as something that's just so important.
Fantastic, loving it. You're doing absolutely brilliant work around stigma, but I was particularly impressed on Friday when you were working, when you emailed me from Soft Play.
Yeah, the other part of my life.
Tell us about soft play?
Soft play, it's chaos. I don't recommend it.
So thank you very much. And finally, Memory Sachikonye, who's been living with HIV since 2002, passionate peer mentor, advocate for women's rights, a member of the European AIDS Treatment Group and co-author of a book coming up very soon. Is that right?
That's so exciting. Yes, our book called Our Stories Told by Us. This is a book that talks about how the African community took part in the HIV pandemic in the UK. It's being launched on the 25th of May. And watch this space for a website where you can order a copy when it's out. It's fantastic.
Fantastic. Brilliant. So let's get on with the questions. So audience, please get your questions across. But first of all, when we talk about HIV stigma, it's used really broadly, but how would you describe HIV stigma, Matthew?
Well, I mean, to be honest, I sometimes struggle with the word stigma because I think it's a word which people who don't have HIV don't really associate. I think it's something that as people who live with HIV, we're all very conscious of it, but maybe it doesn't kind of communicate. So I tend, sometimes at least, to talk more about fear and ignorance because that's kind of where we feel like we can combat those, we can make a difference. But I think there is something else which is very specific about HIV stigma, which is different from the kind of stigma which is associated with other illnesses. I mean, mental health, for example, is very stigmatized. But the difference with HIV stigma is that often it ties in with other forms of prejudice, whether that be homophobia or transphobia or racism or that kind of marginalization of injecting drug users. And I think that's why HIV stigma has become so powerful, because it actually ties in with other prejudices which people have.
Right, no, absolutely. And like Bisi, as a black gay man living with HIV, what intersecting stigma do you think comes from the different communities that you're part of?
I think it's more than that. It's not just that I'm gay, it's not just I'm black, it's not just I'm HIV positive, I'm also an immigrant. And I think that a lot of time we tend to overlook that particular aspect of being somebody who is living here and one trying to navigate healthcare system that you don't understand. And then you start asking questions about, can I have access? So there is that consciousness to deal with, can I talk to my doctor about it? Do I even have the language to talk to my doctor about it? Would they even understand what I'm saying? And then my friends will always have this joke that you're one phone call away, thanks to WhatsApp, to whatever is happening in your life in London. Those African communities will pick up their phone and call somebody in Lagos, in Rwanda, in, wherever on the continent to say, oh, I just saw your son coming out of a hospital. So there's that continuous consciousness of who is watching me, where am I? And just like Matt said, it's this constant fear. And the fear is not most times external, it could be internal as well. Because for me, it was waiting 5 years to start medication because I think people will see me, or because I think starting medication means that I will look positive.
Right.
And I don't want to look positive. I would rather die than look positive.
Right. I mean, yeah, that's really powerful in terms of the experience that you've had, the self-stigma that actually nearly killed you.
Yes.
In terms of stigma. And has that been your experience, Memory?
It's very much resonates with what Bisi is saying. I mean, also as a migrant black woman, coming to the UK and unexpectedly being diagnosed with HIV, you are almost paralyzed, First, you have to think about, of course, the first thing that comes to mind is death. And then what will people say? I come from Zimbabwe, and the time I came to the UK in 2000, before my diagnosis at the beginning of 2001, it was, 2002, sorry. It was a place where if somebody they used to diagnose you with their eyes, like, look at his lips, they are going red. So, okay, who have they been sleeping with? So they will link, oh, it was Bisi, then so-and-so, then they try and make a chain, and then try and link you to everyone. Of course, you're getting that horrible name of, somebody who sleeps around you. They don't even call you like a sex worker or anything. They just call you a prostitute. which is very, very stigmatizing for anyone. I was a professional woman. I'm still a professional woman. And, I was working, so I never thought I would be in that category of being, HIV positive. So coming to the UK, like Bisi says, you don't know what to say or what to do. Luckily, I had people who were supportive around me. So I managed to be directed to a clinic. Even at the clinic, self-stigma is so strong. At the beginning, you think, am I the worst patient here? Is probably my AIDS worse than everybody else in the clinic? So it's a very difficult journey to go through.
Right. Thank you. And Linda, do you find that self-stigma is a real issue for many of the patients that you've seen?
Absolutely. It's a huge barrier for patients to access care in the first place and to remain engaged in care in the long term. It's something that often for people comes back up in waves at different points through their journey with HIV. And at the moment of diagnosis is definitely a key moment where people need support to get through that initial diagnosis, especially when it's been maybe unexpected. But it is true that people may need support even at later stages, even when they've been living with the disease for some time. These, especially when you have to deal with external stigma, you may be reminded of that internal stigma, and things may happen to you that may compound that internal stigma. So it's important that we, certainly as healthcare professionals, but in general as in the community, that everybody has a role in supporting people in living with their HIV.
Yeah, absolutely. And Kat, a survey by THT found that a third of people experience stigma in the workplace. How widespread do you think that is?
So we see a lot of examples of it. We have a casework service for people who experience discrimination. I would say a huge proportion of the cases that we get come to us, and these are people who know that they have suffered discrimination and stigma and they're looking to do something about it. But for each of them, there'll be lots of people who haven't recognised it or maybe don't realise that they have rights that have been breached and don't necessarily raise it. But we see a lot of examples of people who experience workplace discrimination, be it sort of a lack of understanding amongst employers, concerns about things like transmission risk and things that are completely, like non-existent risks that people think they have to, put things and safeguards in place for. But also just, a large portion of the public we know still think that they should be made aware if a colleague is living with HIV. So we know that from public polling results, which is obviously ludicrous, but when people feel that way, it's very difficult, I think, in a situation when you're at work to then feel safe and comfortable.
Yeah, absolutely. And do you find that in social media, Matthew, as well, in terms of getting lots of stigmatising comments around HIV?
Oh, they wouldn't dare. I mean, no. I think it's funny because when I was young and I came out to my mum as gay, the first thing she said to me was, "I expect you'll get AIDS and die then," which sounds like a really harsh, horrible thing to say, but that was her experience. She was working as an occupational therapist, and she had lots of clients who had AIDS, and they all died. And so that was her kind of knee-jerk response. And I think I took that response to me being gay and it became internalized. So then when I was diagnosed with HIV, it was just like, oh God, I've done the worst thing possible. And that became like a huge internal burden for me. And I felt like I couldn't tell my mother. And because I couldn't tell my mother, I couldn't really tell anyone else. And then my mother found out, and she found out because a journalist told her, and it was absolutely awful, really dark period in my life and in my mother's life. But the good thing that came out of that is that once she knew, then I didn't have to worry about anyone else knowing. And so then I could just tell the world. And then as soon as I told the world, as soon as I was just like completely open about it, I just kind of felt this enormous sense of relief because it's just like, this is something I've been carrying around with me for all of these years, and I felt it like a burden. And as soon as I said, I don't care, everything was just simpler. And so I think I do that a lot now, and like I do it on social media, and like if I meet people You know, I mean, like in social situations, I'll slip in the fact that I'm HIV positive really early on because I just don't want that ever to be a barrier, you know, and just like, well, if it's a problem for them, that's their problem. It's not my problem.
Sure, absolutely. And Bisi and Mem, have you found being open about your status helpful?
Oh my God, it's been very, very helpful for me. And because again, I live my life in the public eye in Nigeria, where, you know, I was a victim of that because of my sexuality. I quickly make up my mind to say that whatever you're going to know about me, you will know it from me. And so it was very, very intentional for me to come out. But it was also a very long journey. I didn't come out of, I was diagnosed in 2004. I didn't start talking about my diagnosis until 2010. And that was such a very long, dark period of time that I lost a lot of my friends. People that were really, really close to me died. The oldest was about 30 when he died. So for me, it was me waiting to die. And I remember having a conversation with my doctor at Charing Cross Hospital. And she said, you know, you're not dying, so what are you going to do with your life? Then I realized, oh, I think I can do something with my life now. And I think the first thing I did was coming out to myself first, accepting that, okay, now I'm positive. And then I took that step to come out. And I remember the first time I announced it on social media, my inbox was full of people coming and people going out to take tests and kind of coming back to me and say, oh, I've just been diagnosed. Oh, I did my test. Nothing happened. And I think that was where I got my inspiration from, to always come out every year.
Fantastic.
I mean, I lost, my family lost, 3 cousins, my aunt and uncle, in a space of 1 year. And it was this time where it's just speculative about what they're dying from. Zimbabwe, it was malaria, blood pressure, or diabetes. Those were the acceptable death conditions. So when I got my diagnosis, yes, I was scared, but I quickly told my mom, because I mean, we have experienced this, and I knew that these people were dying from actually AIDS-related illnesses. So when I got diagnosed, got referred for peer-supported positively women then, and I saw these fantastic women living their lives like nothing is wrong. So I thought, okay, so why can't I be like them? So of course I was empowered. I did all the self-esteem courses, got my self-esteem back. I remember I joined Positively UK, I think about April. Then I think I was very sick for a while. And then I went back, started volunteering. In a space of about a year, I was on their magazine cover for Women, Positively Women magazine.
I remember.
And it just makes sense for me to be able to show people that, I'm living with HIV. You can talk all you want, but I'm in control of my life. And then I was lucky enough to be interviewed by CNN for World AIDS Day at some point during that volunteering years. And my phone didn't stop ringing as well. Friends, family all over the world, like, oh, you're the first person I'm telling that I'm living with HIV. How do you do it? Why are you so confident? I'm like, well, I know I'm in control, and I'm getting the best care here. Luckily, I'm getting the care that I need. And that time, nobody didn't have medication, so that probably fueled the stigma as well, that you'll be ill and you have no choice, you're going to die. So that empowerment I got just made me so comfortable in talking about being HIV positive, which I still do today.
Fantastic. I mean, I am really conscious as well that for some people, talking about their HIV status can put them in danger.
Yeah, and I think that's something which we always need to talk about, because I mean, we've been talking about how we as HIV positive people come out, but I think there's also the whole, what is it about the landscape which makes it so difficult? And one of the things which keep on coming up against is that people experience blackmail, they experience abuse, they experience violence. So we need to change the way society is to make it so that it's easier for people to be open. And then when we get more people who are willing to be open, then we get rid of that fear and that ignorance and those misunderstandings.
Yeah, absolutely. And talking about changing society, Kat, you're going to be doing that single-handedly. But I mean, what are some of the attitudes that's come out from your work around society's knowledge and attitudes towards HIV?
Yeah, so we did a survey of the general public in the UK about just under 2 years ago, and I think what's really interesting, but maybe not that surprising, is that generally people don't want to be stigmatising. They don't want to hold prejudicial views. Like they want to be supportive, and in general, I think that the general public are very aware that there is a stigma around HIV. They're aware of its existence. They're aware that it must have a negative impact on people's lives. And when you speak to people, as we did in focus groups, and kind of unpick it, there's a real kind of anger that the general public feel about kind of the negative impact that stigma can have on the lives of people living with HIV. And there's a lot of support for, well, I suppose what you would call enhanced rights for people living with HIV, and kind of policies and things that would support the lives of people living with HIV. But what you get then when you kind of dig a bit deeper and you talk to people is I suppose you have certain blind spots in people's knowledge, and not only their knowledge, but that some of their kind of thoughts and feelings and attitudes. And often people don't recognise themselves, that the things that they're thinking and feeling could actually be stigmatising in and of themselves. But you can start to sort of challenge it, and things. Sort of an example of that, I think, is where you explore relationships with, when you ask people about sort of their level of comfort in sort of entering in sexual relationships with a person living with HIV, or have sort of, if a family member was to tell them that they were living with HIV, the kinds of worries and concerns that they report. I think often they're rooted in kind of a concern about the person, but they're also a concern about what people might think, other people might think and feel about that person, and about kind of the connotations and associations. So it's all of these intersections and layers and things that come up as well.
Yeah, absolutely. And I mean, I'm really conscious that people with HIV face stigma in healthcare settings really frequently. I know for me, when I had cancer, I saw an oncologist, and he asked all sorts of questions about like how I got HIV and what I was doing, not to pass it on to other people. And it can be really awful at those times when we are at our most vulnerable and having to navigate that. What's your research shown around stigma in healthcare settings?
Yeah, absolutely. I mean, this is key. Healthcare settings should be a safe place for people living with HIV. And unfortunately, some of the things that you've talked about, Kat, that the general public hold in terms of beliefs also are true for healthcare workers. We know from the Positive Voices survey and many other surveys of people living with HIV that their experience with healthcare is at times very, very negative. And that certainly at least 1 in 7 in the last Positive Voices survey in the previous year had very negative and discriminatory experiences in the NHS. So we wanted at Royal Free, we wanted to look at what is the level of knowledge of HIV in our healthcare workers, and what are the attitudes towards people living with HIV. So we did a survey last year of our healthcare staff in A&E and in the geriatric medicine unit. We have a particularly aging cohort of HIV patients in our outpatient unit, so we were interested to see what attitude changes there might be there. And it had a really high uptake. 78% of people responded, which shows the level of engagement, which is really unusual for questionnaires. However, it did certainly highlight some very serious issues in terms of levels of knowledge and attitudes. For example, 50% of respondents were aware that if they sustained a needle stick injury from a patient with an undetectable viral load, they could not acquire HIV. And actually, even just knowledge of U equals U was only 15 to 30% of respondents had heard of U equals U. So, this is particularly upsetting in settings like A&E, where we have opt-out testing, and we should be able to offer post-exposure prophylaxis, and this knowledge is key to be able to do that. But yeah, and also this translates to action that means inequitable care and unequal care of patients living with HIV.
Sure. Yeah, and that's really important research that you've done that. I think many of us experience that, but actually to have the evidence to show that's really powerful. Have you ever experienced anything like that, those of you living with HIV?
I mean, it's like, sorry, I'm going to say this, but it's just like asking a black person, have you ever experienced racism? You know, and I remember this adds to one of the reasons why I stopped going out. Maybe I got lucky and then I got a man and I got married, so I don't go out anymore. But I remembered once in Soho and we were having a conversation and I talked about where I come from, and then the next thing the person said was, "Oh, you must have HIV." So, you know, as a gay man who is new, who was new then in the UK and trying to just navigate how to, you know, recover my life, you know, the one that was taken away from me in Nigeria, and then having to get here and just justify why I'm here. It's a big thing. So you have conversation with people, and it's shocking because what you're saying. I mean, we're talking about UK, right? I spend a lot of time in Nigeria. People do not even have understanding of you equals you. It's not even a conversation at the table, and it goes back to when Kat was talking about workplace discrimination. You can't get a job in Nigeria if you're HIV positive. End of.
Wow.
Because companies will do HIV testing before they give you work. And I'm talking about working in financial services. What has HIV got to do with somebody working in financial services? And it's without your consent, right? It's without an informed consent. So when we talk about all the things that, you know, Matt talked about that comes as a repercussion of being HIV positive, one of the things that we've thought has gone off the table that hasn't is poverty. Right. And how HIV in 2023 is driving poverty within the community who are living HIV positive. And not just in Nigeria. You look at it, even in the United States, you know, one of the most equitable country in the world. And nobody is looking at HIV and poverty and looking at ways where we need to change that. Because we can't end HIV if the people who are living with the virus are poor.
Absolutely. No, I think it's really important about that, you know, the intersections that come with HIV. And I'm really conscious that women with HIV face intersecting forms of stigma and discrimination and disadvantage. And Memory, what are you hearing from women in terms of the challenges that they face around stigma?
I mean, migrant women, or black women in particular, they have a lot of challenges. First, most of them will have immigration issues to start with, which in itself is stressful. I was waiting for a decision for 6.5 years. I was lucky enough that I was volunteering, so that took away my stress levels at some point. So these women have an uncertain future here, and you're thinking that if I get deported back home, first there's stigma. And obviously, they will say to you, you've been in the UK for 10, 15 years, what have you come back with? So there's that societal attitude towards people in the UK, and that they don't know that you're living with HIV. And they'll assume that you got HIV from being on the streets in the UK, doing sex work. That's the biggest attitude. They are mothers, some of them. So you have to worry about your children going to school. You have to worry about, poverty. There's poverty in the UK, which we can't deny, especially nowadays with the high cost of living.
Yes.
And even in health settings, I went to my renal checkup before my transplant. I am a very knowledgeable person in terms of my health and everything. My usual consultant was not there. There was a locum, and she was a woman, a white woman, and she looked at my notes, kept quiet, looked at my notes again, looked at me, and said, "How did you get your HIV?" I stopped, I looked at her in the eye, and I said, "My viral load is controllable. I'm well managed HIV-wise. Shall we just focus on my kidneys?"
Yay.
She was a bit stunned. Quickly moved on.
Yeah.
So, you have to stand your ground if you're empowered enough to just say, we're not talking about HIV here, we're talking about something else. We're talking about my kidneys. HIV is under control, there's no problem there. So, not everyone is empowered enough to do that. So, we have to work on empowering our people. In terms of people, in Zimbabwe, we have a lot of social media, and I'm on some of the groups where it's women only. And some of the problems that come is, I found my husband's medication in the shoes hidden in the wardrobe. Oh my God, I'm so scared I'm going to be HIV positive. Then you know what I do? I just take a U=U link and post in the comments. Like, you're lucky he's on medication. You're not going to get infected. They're probably gone for a test and are actually negative. I'm like, you're lucky, you should be happy. He's on medication, or your partner is on medication that you think might give you HIV. Be happy they're on medication, you're not going to get infected. So the information about U=U needs to be sent out or given to everyone as much as we can. This might get people to accept that if somebody is HIV positive and they're on medication, they are not going to pass on the virus. So it might handle the stigma better.
Well, last year I was hospitalised kind of unexpectedly. And I obviously didn't have my medication with me because it was unexpected. And I was hooked up to all these machines, so I couldn't move. And I had a friend drop some medication around, which was very helpful. But then I couldn't get water, I didn't have any water. And I was like, so I said to the nurse, I need to have some water so I can take my medication. And she was like, oh no, you can't do that. And I'm like, I kind of really need to do this. And I started having this big argument with her. I mean, she was very well-meaning because she was concerned about drug interactions and all of that. I mean, I'm not questioning her intentions. But I thought, if I had been any less brazen about my HIV status, this would be a very difficult conversation to have in an open ward with lots of people around. And I think that's one of those things, is that, when you get ignorance about HIV in healthcare settings, it can affect people's health. I mean, you were there for your kidneys, not for your HIV. And it's that's where we see these enormous health challenges. And people living with HIV, we face health challenges which other people do not face anyway. And so to encounter prejudice or stigma in a healthcare setting, it's the worst.
Absolutely. I would say, to tie in with what Kat was saying and what you mentioned there, the intention in a healthcare setting, most people who are working there, they want to do well by the patient. We have to tap into that in order to change the ignorance and to change the attitude towards people living with HIV. And I think what you highlighted there, Matt, is really important. And all of the data, including our survey, really reflects the fact that these things are all tied together. So reduced knowledge means increased fear of acquisition, means worse attitudes towards people living with HIV, and persistent stigmatizing attitudes. And so the three things need to be tackled together, really.
Absolutely. And do you find that for some people who actually stop going to see their doctor, do you think stigma drives people to fall out of care?
Absolutely. I think it's a real problem at the individual level in terms of accessing healthcare and remaining engaged in healthcare, but it's also a real big problem at a service level. So this overall stigma causes a lot of delays in actually scaling up testing of HIV, getting it in all the right places, getting opt-out testing, which we're thankfully now seeing on a larger basis in the UK, at least in high prevalence areas. But there is still work to be done, and tackling HIV stigma will mean getting good access to care, good treatment to everybody who needs it.
Absolutely, and some of the people that I speak to talk about the fact that actually one of the reasons they're not going to the hospital is because there's so many other things going on in their lives, and if people don't have enough money to eat, or if they think that they're going to be deported, or if they're in an abusive relationship, so many of these other issues competing with the need to take your medication. What can we do about that? Over to you. Solution.
Well, I mean, I think recognising the intersectionality of these challenges is really important. And I mean, if you're talking about kind of accessing healthcare and remaining in healthcare, I mean, as Bisi pointed out, you know, if people have an insecure migrant status, that's going to be a real challenge. Trans people, from the Positive Voices survey, trans people often dropped out of care because they felt they couldn't get an attitude when they were receiving healthcare which was accepting and supportive. So I think we've got to look at how society is structured. And it is always the thing with HIV, is that HIV is a condition which mainly affects people who belong to already marginalised communities. And so that has allowed stigma to flourish, which I think we all know that if this was a disease which mainly affected white, cisgendered, heterosexual men, we wouldn't be talking about stigma here today, would we?
Exactly.
Yeah, very, very true. And do you think that the current political situation where we're in at the moment, and the whole anti-woke agenda and the hostility towards trans people, do you think that's making HIV related stigma worse?
Well, I mean, I think anything that makes things worse for people who live with HIV is going to make HIV stigma worse. And you know, I think people with HIV and people who belong to communities of high HIV prevalence, we're an easy target, and we're a distraction. We can be used as a distraction, and that's the problem. I mean, at the moment, the country is facing all sorts of major problems, economic problems, trade problems. So we shouldn't be talking about trans people. That's not the major problem. We should just let trans people get on with their lives. And, you know, and quite frankly, it's ridiculous. Oh, no, I don't want to get into the whole kind of the migrant stuff, because I think what we need to focus on in this discussion, at least, is how does that make it harder for people to access healthcare?
But I think that we need to talk about the migrant issue. And I know how tricky it is for a conversation in this country. So I remember 2010, and I think UK CAB and THT and NAT were very involved in that campaign for universal access, right?
Yeah.
Because prior to that time, you can't have access to HIV medication if your immigration status is not settled, right? So there was a backload of people who are of African origin who couldn't have access to HIV treatment because they do not have a settled status here. And the argument that was used, because I was one of the faces that was part of the campaign, and I spoke a lot about it. The argument that was used was the fact that you can't stop how people relate in a society. Relationship, sex, or whatever it is, does not ask for immigration status.
Absolutely.
So you see somebody you like the person, and something happened. But because that person has been denied access to manage their HIV, they are at a very high risk of transmitting the virus. So if we provide universal access to HIV medication to everyone, we can reduce the spread of the virus. It's a simple science thing. What is now happening is we're going back to pre-2010 in this country with the aggressive approach to immigration. Because a lot of people that are coming here via the boat that we are stigmatizing at the moment, many of them have HIV, and they can't have access. They can't even think of wanting to have access because they're afraid, they are scared, they think that the government is after them. But the reality is they are mingling with people in the community, right? And I think if for anything, I feel this is a conversation that we should be having. Let people have access to universal healthcare when it comes to communicable diseases, because that's the only way we can control it. And it has to be, stigma has to remove. We have to remove stigma from it. Immigration status have to go out of the door. And, so we cannot talk about stigma, and it's part of the many problems that people have. We can't talk about all of these things without really talking about, this unreasonable anti-woke war that this government is so focused on, considering that British people are not even interested in it. We saw that from the last election. Nobody cares about woke and not woke. Nobody cares about trans people. People want to turn on their heating at home and make sure that they don't have to go bankrupt for it. People want to have access to things that they should have access to. And we have, okay, I'll stop there.
I think what's really interesting about what you're saying about that argument is ultimately this is it's a health rights and equity issue. But it's an argument that we won based on the public health argument. We had to make a broader public health argument, but what it demonstrates is that ultimately if you help people to realise their rights, and in this case that was their health-related rights, access to treatment and care, that otherwise without it, it would put their life at risk, you actually have wider societal benefits. We won that argument in this case, but that argument can be translated across the board. But I think, just going back then to think about kind of why this matters, why kind of the current environment matters, kind of all of the stories here, it's all about kind of dehumanization of people. So if people are being told in other parts of their life that they are less than in some way, and then on the other hand, we're kind of having a conversation about why we shouldn't stigmatize them for one health condition. You can't view that one thing in isolation without all of these other things. And at the sharp end of it, when you think about kind of someone just accessing healthcare and the fact that unless they are empowered and in a position to be able to say certain things and stand up for themselves, how many people are going to have the experiences that you guys have talked about who will never go back into the NHS, who will never access healthcare again? And the data keeps telling us time and time again, for every one person who has experienced something in healthcare, a negative experience in healthcare related to their HIV status, then there's even more who will avoid healthcare because of the worry about that. So it takes a long time to undo the harms of any kind of things like that, and we have to work twice as hard.
Yeah, absolutely. And I hear a lot from people who say to me, I went to the clinic, particularly in relation to black women just not being believed. And people are often saying, what is the point? What's the point of going back when the same thing's just going to happen and no one's going to listen to me and no one's going to believe me? So how can we, within the health service, actually address that, these health inequalities that people are facing that fuel stigma?
Absolutely. I think some of the solutions we've kind of already talked about in a way. Part of it is to really give people more training, more exposure to the stories of people living with HIV. And we know that works. We know that reduces stigma. We've seen that in our survey as much as in lots of other work beforehand. So what we know, for example, as much as the results that I've shared here today might seem very concerning, quite rightly, from the lack of knowledge point of view. Those same respondents, 86% of them want more training in HIV. So it's on us to now deliver that. And as third sector organizations in this country have lots of experience in bringing the stories of people living with HIV to these small group teachings, is an amazingly powerful tool for people to step back outside of their busy clinical environment where they have to make decisions under high pressure and almost in a subconscious way, to an environment where they can really think about how their actions and how the way that they treat people impacts their experience of healthcare. And actually reframing that, giving them also a safe space to ask the questions that they're not sure that is okay to ask. So at the Royal Free, we've already started. Dr. Ellie Hamlin, one of the HIV consultants, has recently had Angelina Namiba come
Hi,
Angelina, from Mentor Mothers, and they did a fantastic session that was incredibly well received in the labour unit with the staff there. So in a way, perhaps we are also seeing a little bit of the downside of having such fantastic HIV services in the UK. You know, the Ian Charlson Day Centre at Royal Free is historically one of the biggest units, outpatient units in the UK, very forward thinking. They have a walk-in service, so people living with HIV known to the service can come in and get care for any medical issue there. This in a way has sheltered the rest of the hospital from that exposure to people living with HIV. And so I think we have that responsibility now to do regular education and outreach to the different departments.
Yeah, I mean, that's a very important point. And I think that perhaps some of the stigma that we have comes about from, you know, well-meaning people. And Matthew, how do you think, you know, the old sexual health campaigns, how do you think that played into stigma?
I think I was going to say, how did the old people think about it? Yeah, I mean, I think it's really interesting. I think we look back on the kind of, in the UK, it was the kind of the iceberg and the tombstone, and it was this kind of very kind of doom-laden voiceover, and, you know, there is a disease kind of thing. And I think that did have an impact, and I think I think it's very easy in retrospect to say that was very stigmatizing. I think at the time they had much less idea of how transmissible HIV was. I think there was a fear that it was going to be spread through all populations much faster than it actually did, and so I think they just needed to. They felt the need to do something with impact, and I'm glad they did something. I mean, you know, because we looked at what happened in the US, where they did nothing for years and years and years. So I'm glad that actually in the UK we got off the marks a bit faster. But I do think at the same time that shadow of the iceberg and the tombstone is something that we all still live with. And I think when we talk about things like U equals U and we say, well, you know, we can challenge stigma with information, I think we have to remember how deeply ingrained some of that fear is. Because we worked at it, not me, you know, but I mean, as a country, as a society, we told people you need to be really afraid of this. And so then when that information changes, by which point it's like being inserted into our DNA, that fear. And so we've got to a certain extent, be patient, but also be obstinate. You know, we need to make sure that as many people know that when someone is on effective treatment, there is no risk of passing the virus on during sex.
Right, yeah, the U equals U message is really powerful. Do you think enough people know about it?
No.
or actually believe it.
I mean, we know that they don't.
Yeah.
I think even if U equals U, we know what it means. We all know, you know, undetectable equals untransmissible, but it's quite difficult, I think, for that to land with a member of the general public. But even when you say to the general public, do you know that HIV treatment has this effect? And you know that someone on effective treatment can't pass it on, you know, only I think it's less than 1 in 5 of the general public have even got an inkling of that. It's about 16% of the general public think that that's true. So there's a lot of work to be done there. But thinking about what you were just saying, Matthew, as well, I think we have a hard task here because from a public health perspective, fear is a much easier emotion and message to instill in people and get across than reassurance. And sort of what we found when we have been talking to people about the U equals U message and sort of talking to them about it, it takes a lot for people to really believe it and absorb it. And you get a lot of things like, you know, people saying things like, well, there's no such thing as zero risk and whataboutism and things like that you know, these take a lot to overcome, but I don't want to diminish how powerful a message it is as well, and how important a message it is, and how hopeful it is as well. So there is, it's about how we build that into a more positive narrative and change the story, I suppose.
Absolutely, and I'm also really conscious that there are so many people around the world that still do not have access to treatment and can't benefit from the U equals U message.
Yeah, and I think that is where the global conversation around U equal U is, and it's very much to who, for who, and where. So it depends on where you are in the world and the kind of access that you have. Because, blind me, people are still taking D40. People are still taking AZT. And we know how toxic and how dangerous these drugs are. And it's driving people away from ever wanting. And you talk about that because the first kind of exposure to support that you get during diagnosis will have a large impact on your adherence and how you present your life. So if your first drug is D40, you possibly are never going to take any other drugs anymore. But last thing I'm just going to say that I don't think that training is a problem. I think that we are asking people who are dealing with the burden of a virus to give service for free. And that is what has driven a lot of people away from HIV activism because it's draining. And then you go back home, you still have rent to pay, you still have bills to pay, and there is no support because everybody wants you to do this thing for free. Maybe it's time we go back and reinvest into, you for you, because I don't see reason why it's at the stage and scale that it should be more than this. If we were able to scare people in the 80s and 90s away from HIV, we should be able to bring them back to the information just to save money.
Absolutely, and just thinking a little bit more on the international situation, I mean, currently there is just these most horrendous homophobic laws that are coming around in a number of African countries now. What impact do you think that's going to have in relation to HIV stigma?
A lot. I mean, don't let's just talk about what it will have. Let's talk about what it is having in Nigeria, where the law is already in oppression. So what we're seeing in Uganda, it's coming, right? So we can project what will happen. In Nigeria, HIV uptake amongst gay men has gone down. We're now having high rate of sexually transmitted infections amongst gay men in Nigeria. And we now have a high rate of nurses who have turned to quasi police and reporting HIV positive gay men or men who have any symptoms of sexual health infection to the police, because that's what you're supposed to do. So you're driving these people, young generation, TikTok generations, you're driving them away from having access to healthcare. Imagine the epidemic that is looming in the next 10 to 15 years.
Absolutely, and I've heard of a friend of mine who lives in Kenya, the impact that's having there, and the laws that are coming in there. It's really terrifying. We've got a question. Go ahead, Matthew.
I was just thinking about a presentation I saw at the AIDS conference last year, which is also talking about HIV stigma, experience of HIV stigma in healthcare settings in Kenya and I think it was in Zambia. And it was, again, that intersectionality of, people would go for HIV care and they would be made to feel, that, whether or not they were a sex worker, they would be made to feel that they were a sex worker, including people who had lifetime experience of HIV. They were kind of questioned about their sex life in ways which felt really intrusive and judgmental. And I mean, the law, what's happening in Uganda, but also, as you say, those laws are already on the books in Nigeria. In Kenya, it's looking bad. But it's not just sub-Saharan African nations. I mean, there's also Eastern Europe, Central Asia. Look at states in the United States.
United States of America.
Florida's not looking good. And Tennessee has all these laws on their statute books which criminalise behaviour from an HIV positive person, where if an HIV negative person does it, there's no criminalisation.
Exactly.
Yeah, no, absolutely. Those kinds of criminalising laws have such a terrible impact globally. I've got a question from the audience. How can the type of language used about HIV make stigma worse? And what type of language would improve the stigma around HIV? Who would like to take that?
I can.
Yeah.
Well, I can try. I mean, if you are called HIV, if you are called this person is HIV infected, I hate that word. That's so stigmatizing for me. I'm a person living with HIV. It's good enough. So I think some of the language, simple language, like you can't call a person infected. Yes, I'm living with HIV. I'm not infected. It makes it look like I'm going to infect everyone around me.
Yeah.
But so I think language is very important. And also, some places you are kind of made to feel very small, like, oh, that's for people, that's for AIDS patients.
Yeah.
There's nobody living who has AIDS these days. It's all HIV. So little words can really make a difference to people's attitudes, you know. I mean, I see people who say, I mean, they probably want to say that I've got AIDS, but I just, you know, like say, no, I'm living with HIV. I'm living positively with HIV, so that, you know, you can change attitudes with language.
When I was doing when I was running a lot, and this is sort of an example of experiencing stigma on social media, and someone said, "How can you run with AIDS?" and I replied, "The same as you, but faster." But I mean, in terms of the language, I mean, I completely agree with you, Memory. But I mean, also, I mean, there's kind of the sex language. So it's like, you know, are you clean?
Yeah, oh my God, yeah. You talk a lot about that on Twitter, about people asking that question.
It's you know, I mean, that's just nonsense. But I also hate it when people say, well, I mean, like, when I had my last COVID vaccination, it's like, oh, so you're suffering with HIV.
Oh,
I'm like, well, you know, some days, but, you know, hangovers more. Or if I read something that's saying, you know, victims, it's like, I don't want to be called a victim. I never want to be called a victim. It's so disempowering.
Absolutely.
Just to add to that, one of my friends, you know, we are all into this dating life, so she met this person and they were talking about health, you know, just, you know, and he asked the person, my friend, like, so what do you have? And she goes, oh, I have 2 boys.
Oh gosh. Yeah. I have a credit card.
I'm a killer smart.
We've only got 4 more minutes. So, Kat, in terms of actions to like try and fix stigma, well, what? No, just you know, you personally, but what's the HIV charter mark, and what difference is that going to make?
Well, I'm hoping it's going to make a huge difference. So the HIV Charter Mark is a new initiative. It's a new programme that is being initially commissioned by Fast Track Cities London, but it's going to be a UK-wide initiative. And we are developing at NAT in partnership with NAM and with Positively UK, but hopefully involving many other people as well. We're developing what will eventually be something that different organisations, probably starting with healthcare organisations in the UK, can sign up to in order to access lots of kind of up-to-date training, information, materials, ultimately with the aim of making sure that those organisations are, I use this term loosely, but an HIV-friendly place. But I like to think of it more as like, for me, having that charter mark there, having sort of, as a person living with HIV, if you are accessing a service and you see that charter mark, you need to know that you should be safe accessing that service. That's ultimately what this is about. But we think that can have a huge impact if we can get this right, because not only does it have an impact on making sure that people can access those services and those organisations, and the people that work for those organisations will kind of, I think, benefit from it because they will learn more and they will provide a better service to people living with HIV who access. They will also go out into their communities and wider society and have an impact as well. And especially if we're thinking about, you know, healthcare institutions, you know, if you ask the general public where they go to for the most trusted information on HIV, it's always healthcare institutions, but it's not necessarily the ones that we know have expertise in HIV. It's your GP, it's your local pharmacy. So it's really important that these institutions get it right. And ultimately, it's really important that other public services get it right as well, and that places where people are accessing information or services on a day-to-day basis are not doing things that are just reinforcing, stigmatising and negative attitudes. So that's the idea behind it.
Yay, fantastic. Wonderful to be part of that. And we've only got 2 more minutes, oh my goodness. So one final quick fire question. Starting with you, Memory, from all of you, one action that someone can do to help stop HIV stigma.
Be visible. Stand up and say, I'm living with HIV. Well, nobody can judge you.
Fantastic.
I'm going to do 2, but I'm going to say learn some basic facts, find out more about HIV, but try to combine those with finding a story, an article, something written or said by someone living with HIV as well.
I mean, obviously, be brazen, because that's what I do. But I think it's also sometimes about telling people why you're telling them that you're living with HIV, because you want to make it easy for the person to hear as well.
Fantastic. Linda?
Get a HIV test and tell all your friends to get a HIV test. I think we should be normalizing it. Just like a diabetes test, you get a HIV test, and everyone's at risk. Don't stick to historical stigmatized beliefs of who gets it, why they get it, when they get it. Everyone's at risk. Get tested.
Fantastic. Finally.
And learn something about you equals you, because you might need it tomorrow, you never know.
Fantastic. Undetectable equals
Untransmittable.
untransmittable. Spread that message, everyone. So I think we are now out of time. Thank you all so much for coming on. I could keep on chatting to you for ages. This has been like really fun. So thank you. Thank you to amazing Disruptive Live team. Yay, you are brilliant as always. Thank you all for listening. If you have enjoyed this broadcast by NAM aidsmap, next week we have the Health and Power broadcast on health inequalities. So do tune in on Monday next week for that. I'll be joined by Dr. Vanessa Appiah and amazing guests to talk about health inequalities. So hopefully see you then, and thank you all again. Thanks, bye.